Hello and welcome back everyone. So in this video we will talk about the pediatric arrhythmias. This is part of the pediatric intensive care series that we will discuss on this channel, and this is requested by a channel member, and here we will discuss the definition, complications, treatment, antiarrhythmic drugs, sinus arrhythmia, sinus bradycardia, wandering atrial pacemaker, extrasystoles including PACs and PVCs, supraventricular tachycardias including AVRT, AVNRT, atrial flutter and atrial fibrillation, and ventricular tachycardias including VT and VF. And this is the most comprehensive video on pediatric arrhythmias that you will find on the internet. So let's start with the basics. So arrhythmia is a disturbance in heart rate or rhythm. This is caused by a disturbance in the impulse generation and propagation within the cardiac electrical system, or due to a problem within the tracts within the electrical system itself, leading to bradycardia, tachycardia, or irregular rhythm. And arrhythmia can be congenital, such as congenital long or short QT syndromes, or it can be acquired, such as a complication to congenital heart diseases, or as a complication to the repair of the congenital heart diseases, or due to toxins or drugs, or it can be due to the fetal inflammatory response syndrome, because in the fetal inflammatory response syndrome, the fetus would acquire an infection from the uterine, an intrauterine infection, leading to neonatal sepsis, organ damage, and it can lead to arrhythmias. Now, arrhythmias may lead to many complications, so it may lead to acute decrease in cardiac output, leading to heart failure, or it can degenerate into another type of arrhythmia, for example, ventricular fibrillation, or if continuous, it may lead to cardiomyopathy, and all of these outcomes may lead to syncope and sudden death. Now let's talk a little bit about the treatment. So arrhythmia can be treated with medications, which are called the antiarrhythmic drugs, that will be discussed a little bit later on this video. And it can also be treated with transcatheter ablation. This is done for recurrent arrhythmias or arrhythmias that are resistant to treatment. Now we also have implantable pacemakers. Those are used in patients with the bradycardia, and they can be small to be applied even in premature infants, so they are a very valuable resource. And we also have defibrillators. Implantable defibrillators are applied in patients with malignant arrhythmias to reverse the arrhythmia when it occurs. Now let's talk about the antiarrhythmic drugs. Now it is important to know that the use of the antiarrhythmic drugs is dropping in favor of the curative ablation procedures, because these procedures would prevent the side effects of the antiarrhythmic drugs and they cure the arrhythmias. And it's also important to know that the majority of the antiarrhythmic drugs are not approved by the FDA for use in children, and they are used off-label, and the arrhythmia mechanism may be different for the pediatric patient than the adult, because the heart rate is different for the pediatrics, it's higher, and the refractory periods and the conduction times is also different for the pediatric population. Now also, there may be a marked difference in the antiarrhythmic drugs pharmacokinetics by age in comparison with adults, because infants may have slower absorption and gastric emptying than adults, and children in general would have different sizes of drug tissue compartments, affecting the volume of distribution of the medication, and also the hepatic metabolism and the renal excretion may be different for the pediatric population than the adult. Now, the antiarrhythmic drugs are categorized according to the Vaughan-Williams classification, and the Vaughan-Williams takes into account the phases of the cardiac action potential. So the cardiac action potential starts with the sodium in, then the potassium chloride out, then the calcium in, then the potassium out, and then the potassium back in. So the Vaughan-Williams contains 4 classes of medications. Class 1 include agents that block the sodium channels, and the first class is subdivided into 1A, 1B, and 1C. So class 1A is the moderate blockage of the sodium channels for medications such as quinidine and procainamide. Class 1B is weak blockade of the sodium channels in medications such as lidocaine and phenytoin. And class 1C is a strong blockade of the sodium channels in medications such as flecainide and propofane. Next, we have the class 2, which include the beta blockers such as propranolol, metoprolol, and so on. And then we have class 3, which include medications that prolong repolarization by blocking the potassium channels, such as you can see here. So it prevents the potassium from coming out in medications such as the amiodarone and the sotalolol. And finally, we have the class 4, which work on the calcium channels, and it includes the calcium channel blockers, such as you can see here. So we have the verapamil and the diltiazem. Now let's talk about some examples of arrhythmias, and let's start with the sinus arrhythmia. So the sinus arrhythmia is a normal physiologic variation in the impulse discharge from the sinus node related to respirations, and it occurs in healthy children. And the heart rate slows during expiration due to increased vagal tone, and accelerates during inspiration due to decrease in the vagal tone. And occasionally, if the sinus rate becomes too slow, an escape beat arises from the atrioventricular junction. Now, if these escape beats are too frequent, it may mimic frequent premature contractions, but the relationship to respiration could be appreciated with careful auscultation. Now, drugs that increase the vagal tone may exaggerate the sinus arrhythmia, but this could be abolished with exercise. Now, on ECG paper, the sinus arrhythmia is characterized by a variation of the P to P interval. So this is one P to P interval, and this is the next one. There is some variation between them, and there is no change in the P wave morphology and no change in the PR interval. Now let's talk about the sinus bradycardia. So the sinus bradycardia is a slow discharge of impulses from the sinus node, and it is considered sinus bradycardia when the rate is less than 90 beats per minute in neonates and less than 60 beats per minute in older children. And the sinus bradycardia is common in premature neonates and in neonates with low birth weight, and it is associated with periodic apnea. Now, in older children, sinus bradycardia mostly occur in healthy children, and it may be associated with hypothyroidism and conditions with high vagal tone such as gastrointestinal tract obstruction or elevated intracranial pressure. And sinus bradycardia is frequently associated with junctional escape beats and premature atrial contractions. Now, on ECG paper, the sinus bradycardia is characterized by a normal P wave and a rate that is less than 90 in neonates and less than 60 in infants and older children. Now let's talk about the wandering atrial pacemaker. In this condition, the pacemaker is wandering. It's repeatedly changing its position within the atria. So it is an intermittent shift of the pacemaker of the heart from the sinus node to other part of the atrium. And this is common in healthy children, and it may be seen in association with sinus bradycardia. It occurs as an escape phenomena due to the sinus bradycardia. So the escape phenomena of the sinus bradycardia include premature atrial contractions and junctional escape beats and wandering atrial pacemaker. Now on ECG paper, the wandering atrial pacemaker is characterized by a P wave that is present, but it is different in shape between beats depending on its origin, if it is sinus or atrial. So here you can see a one shape for the P wave. On the next beat it's also different, then on the third beat it's also different, and so on. And there may be fusion between the sinus P wave and the ectopic atrial pacemaker P wave. Now let's talk about the extrasystoles. Now extrasystoles are produced by the premature discharge of an ectopic focus that may be situated in the atrium, the AV junction, or the ventricle. So the extrasystole is a premature beat. It occurs prematurely and it is originating from the atrium, the AV junction, or the ventricle. And depending on its origin, it is divided into premature atrial contractions, PACs, and premature ventricular contractions, PVCs. Now, isolated extrasystoles are of no clinical or prognostic significance, while frequent extrasystoles may be caused by organic heart disease such as inflammation, ischemia, and fibrosis, or drug toxicity. So let's discuss the premature atrial contractions. So those are common in childhood in the absence of heart disease, and depending on the degree of prematurity of the beat and the preceding R2R interval, the PACs may result in a normal or a prolonged or an absent QRS complex. So the premature atrial contractions can result in a normal QRS complex, or they can result in a QRS complex that is prolonged, which is called aberrancy, so such as you can see here, or they can result in an absent QRS complex, such as you can see here. And this all depends on the prematurity of the beat, on how premature the beat is, because this is related to the refractoriness of the AV node and the rest of the conducting system within the ventricles. If it is still in the refractory period, the impulse would not propagate, so there would be no QRS complex. Now on ECG paper, it may show a premature P wave superimposed on and deforming the preceding T wave, or a P wave that is premature and has a different contour that of the other sinus P wave. So as you can see here, we have a normal beat here, and then we have a premature atrial contraction, and you can see the P wave of the PAC is superimposed within the T wave of the preceding normal beat. Now the PAC may reset the sinus node pacemaker, leading to incomplete compensatory pause. This means after the PAC there would be a pause, then a normal beat would occur. Now let's talk about the premature ventricular contractions. Those arise in any region within the ventricles, and they are characterized by a premature, widened, bizarre QRS complex that are not preceded by a premature P wave, and they are classified as uniform and multiform. Uniform when all of the beats have the same contour, meaning they are originating from a single focus within the ventricles, or they can have multiform, that is when they have different contours, meaning they are originating in different focuses within the ventricles. Now, premature ventricular contractions often but not always followed by a full compensatory pause, such as you can see here. So the PVC, as you can see here, is followed by a compensatory pause, and then comes a normal beat. And this is longer than the non-compensatory pause the premature atrial contraction is followed by a non-compensatory pause. This is shorter than the full compensatory pause followed the PVC. Now, presence of the fusion beats proves the ventricular origin of the premature beat. Now, a fusion beat occurs when a normal beat is propagated within the ventricles, a normal beat comes from the sinus node, and at the same time, a premature ventricular contraction is propagated within the ventricles. So when those beats occur together, the result would be a hybrid beat that is called the fusion beat that would prove the ventricular origin of the premature ventricular contraction. Now, generally speaking, extrasystoles produce a smaller stroke volume and pulse volume than normal, and if they are premature enough, the radial pulse can't be felt when there is a premature beat. And frequent extrasystoles may lead to a definite rhythm. Example, bigeminy. Bigeminy is a premature beat occurring after every one normal beat, such as you can see on this ECG here. So we have a normal beat, then a premature beat, normal, then a premature, normal, then a premature, and so on. This is bigeminy rhythm. Or it could be trigeminy, that is when the premature beat occurs after two normal beats. So we have two normal beats, then an extrasystole, two normal, extrasystole, and so on. Now, most patients are unaware of a single premature ventricular contraction, while some may be aware of a skipped beat over the precordium. The skipped beat sensation is caused by an increased stroke volume of the normal beat after the compensatory pause. And when the stroke volume is higher, there would be a feeling of a skipped beat. Now, anxiety, febrile illness, and ingestion of various drugs or stimulants may exacerbate the premature ventricular contractions. Now, it's important to distinguish the premature ventricular contractions that are benign from those that are likely to lead to more severe arrhythmias. And for this to be appreciated, there is a specific criteria. So the criteria to furtherly investigate the premature ventricular contraction include if there is two or more premature ventricular contractions in a row, the premature ventricular contractions has to be furtherly investigated. And when there is multiform PVC, that is when the PVC contour is different, meaning they are originating from different focuses within the ventricles, and when there is an increased ventricular ectopic activity with exercise, because this means that there is some kind of ischemia leading to increased ectopic activity within exercise, and also R-on-T phenomena. R-on-T phenomena means that the ventricular ectopic beat occur on the T wave of the previous beat, and this is dangerous because this can trigger a fatal arrhythmia such as ventricular tachycardia or ventricular fibrillation. Also, the PVCs has to be investigated when there is an extreme frequency of them and when there is presence of underlying heart disease or a history of heart surgery or both. Now let's talk about the treatment of the premature beats. So for the benign PVCs and PACs, is reassurance that the condition is benign. Changes must be made to remove the triggers such as caffeine or any other trigger that is identified, and also, if frequent, there may be counseling on the suppressive therapy of the antiarrhythmic drugs must be made to decide whether to use them or not. Regarding the malignant PVCs that are usually secondary to another clinical problems such as electrolyte disturbance or cardiac ischemia or cardiac surgery or certain drugs or toxins, they are treated by treating the underlying cause, and they also benefit from the suppressive therapy using lidocaine and amiodarone for refractory cases. Now let's talk about the tachycardias. So we have the supraventricular and the ventricular tachycardias. Now the supraventricular is every type of tachycardia that is originating above the bundle of His. So this is here is the bundle of His. So everything originating above the bundle of His is considered supraventricular, and everything below the bundle of His is ventricular. Now there are many types to the supraventricular tachycardias that will be discussed, including the atrioventricular reciprocating tachycardia and the atrioventricular node re-entry tachycardia and the accelerated junctional rhythm and the multifocal atrial tachycardia and the atrial ectopic tachycardia and the atrial fibrillation and the atrial flutter. Now also we have multiple types of the ventricular tachycardias. Mainly we have the ventricular tachycardia and the ventricular fibrillation. Now regarding the supraventricular tachycardias, so their onset is abrupt. They occur abruptly and the pulse rate during the supraventricular tachycardias is above 180. It's around 300 beats per minute and they may last from seconds to hours and they rarely lead to complications. But if they last for a long period of time or when the heart rate is exceptionally rapid, they may lead to heart failure. Now in infants, because they can't communicate their symptoms, they would present with heart failure if they have a prolonged supraventricular tachycardia. And presentation of heart failure in infants would be a pale color with tachycardia and tachypnea and hepatomegaly. Now let's talk about the atrioventricular reciprocating tachycardia, the AVRT. This type of supraventricular tachycardia occur in the presence of an accessory pathway and in conditions such as Wolff-Parkinson-White syndrome. So let's talk a little bit about the Wolff-Parkinson-White syndrome. Now this syndrome is characterized by the presence of the accessory pathway, which is called the bundle of Kent. Now normally the area between the ventricles and the atria is sealed. That means that there is no impulses that can pass from the atria to the ventricles, only through the AV node. So this area is sealed normally. There is no impulses that can pass through this, only through the AV node. Now if we continue to draw the atria and the ventricles, so here we have the right atrium, the left atrium, the right ventricle, and the left ventricle. So in Wolff-Parkinson-White syndrome, we have the bundle of Kent here. Now normally the impulses start at the SA node and then moves on to the Bachmann bundle to the left atrium to allows for contraction of the left atrium muscle and the right atrium at the same time, and then moves on through the internodal tracts to reach to the AV node here, and then at the AV node the signal is slowed by 0.1 millisecond because the tissue of the AV node slows down the impulses by 0.1 millisecond, and then it is passed through the His bundle and into the bundle tracts and through the Purkinje fibers, and this would lead to the heart beating. Now if the AV node doesn't slow down the impulse, this would lead to the atria and ventricles contracting at the same time and pushing the blood against each other and not allowing the blood to go out of the heart. And this is problematic. So the AV node slows down the impulse, allowing the atria to contract first and then the ventricles to contract after. Now in Wolff-Parkinson-White syndrome, we have a bundle tract that is called the bundle of Kent that is connecting the atria to the ventricles, and this allows the impulse to travel through very fast. And this means that it doesn't slow down the impulse like the AV node does. It allows it to flow as rapidly as the other bundle tracts available. And this is the problem with the Wolff-Parkinson-White syndrome. Now in the Wolff-Parkinson-White syndrome, there is ECG changes that can be appreciated in the absence of the arrhythmias. So when there is no atrioventricular reciprocating tachycardia, there would be ECG changes present. Those include that there is a short PR interval. That is because the impulse is traveled through rapidly to the ventricles. So the PR interval would be short, and the QRS complex would have a slow upstroke that is called the delta wave. So the QRS complex would start like this, and it would go on to continue like that. So a short PR interval and then a slow upstroke of the QRS complex, that's called the delta wave, and that is because the ventricles would start rapidly contracting after the atria because the impulse is traveling fast through the bundle of Kent, as we mentioned. Now during AVRT, one of these impulses traveling through the AV node would come back through the bundle of Kent and travels in a retrograde fashion. And this would lead to the impulse going back through the atria and into the AV node and through again and then through the bundle of Kent into the atria and so on until we have the atrioventricular reciprocating tachycardia. Now on the ECG paper, we would have a P wave that is also a T wave of the previous beat, and then we have a QRS complex that is narrow, and then a T wave that is also a P wave for the next beat, and a narrow QRS complex, and then a T wave that is also a P wave, and a QRS complex, and so on. And this is atrioventricular reciprocating tachycardia. Now the opposite can happen. The bundle of Kent can allow the impulses to travel antigrade through the ventricles, and then they go back retrograde through the AV node. It would be exactly the opposite of the AVRT, but this time we would have a wide QRS complex, and this may occur in the presence of atrial fibrillation, and it may degenerate into ventricular tachycardia or ventricular fibrillation and death. That is why patients with Wolff-Parkinson-White syndrome have a small but real risk of death from such arrhythmias, and risk stratification and a 24-hour Holter monitoring is recommended to make sure they don't have a great risk of death. So if they do, then electrophysiological study and catheter ablation should be done. Now let's talk about the AV nodal re-entry tachycardia. This is different from the AVRT. In this type, we don't have an accessory pathway, but it occurs within the AV node. So to understand this, we have to make the AV node a little bit bigger. So here we have the AV node, and below it we have the bundle of His and the bundle tracts. So in the AV node, we have a fast pathway and we have a slow pathway, and each of them have a different refractory period. So the fast pathway have a slow refractory period. The slow pathway have a fast refractory period. So normally when the impulse is traveled from the SA node to the internodal tracts and then to the AV node, it travels through both the fast and the slow pathway, and it reaches to the bundle of His. So when it travels first through the fast pathway, travels fast, and then the fast pathway would go into a refractory period, and at the same time it travels through the slow pathway, and the slow pathway would go into the refractory period and then moves on to the His bundle. Now if the impulse is premature enough, it would reach at a time where the fast pathway it just got out of its refractory period, but the slow pathway is still in its refractory period. So it would go through the fast pathway first, and then when it reaches through the His bundle, it would go into the His bundle, but at the same time, the slow pathway would be out of its refractory period. So it would travel back through the slow pathway, and then it would find that the fast pathway had undergone its refractory period and is back from its refractory period. So it would travel back through the fast pathway and then into the slow pathway, and so on, enters a loop in the AV node. And this would lead to many impulses traveling into the His bundle now, leading to the AV nodal re-entry tachycardia. So the ECG paper would show a P wave that is also a T wave of the previous beat, followed by a narrow QRS complex, then a T wave that is also a P wave of the next beat, and then a narrow QRS complex, and so on. Now the narrow QRS complex is less than 0.08 of a millisecond, meaning it's less than 2 small squares in both of these types of tachycardias, and the heartbeat is above 180 and it's around 300 beats per minute. Now let's talk about the SVT treatment in AVRT and AVNRT. So vagal stimulation is done first using the Valsalva maneuver, straining, breath holding, or standing on their head. And if these fail, then adenosine can be given at a dose of 0.2 milligram per kilogram. Maximum is 12 milligrams, can be repeated 3 times. If it doesn't work, then DC cardioversion can be given. Now, if heart failure occur in infants, then the heart failure can be reversed by reinstituting the normal sinus rhythm, and the cardiac output can go back to normal after days to weeks of reinstituting the normal rhythm. Now, in refractory supraventricular tachycardia, Holter monitoring is done 24 hours to monitor the recurrence of the tachycardia, and electrophysiological studies are done after. That is by placing multiple electrodes in the heart. Those are transvenous electrodes, and then mapping is done, and initiation of the arrhythmia to locate the bypass tracts is also done, and catheter ablation of the accessory pathways is done. Catheter ablation is recommended for patients on multiple antiarrhythmic drugs who have poor control of their arrhythmias. Also recommended for patients who can develop arrhythmias such as VT and VF, which lead to a great risk of death. Now let's talk about the atrial ectopic tachycardia. And this type of tachycardia is originating from a single focus within the atria other than the SA node. And this type of tachycardia, the heart rate is around 200, and this is hard to control, and the best treatment is with catheter ablation. Now let's talk about the multifocal atrial tachycardia. Now this is originating from multiple different foci within the atria. It's more than 3. This would lead to different contours of the P wave. Now this is common in infants without cardiac disease, and the goal of treatment is to slow down the ventricular rate, because this arrhythmia is difficult to treat and it would go away by itself by 3 years of age. Now let's talk about the accelerated junctional ectopic tachycardia, the JET. Now this type of tachycardia is automatic, non-re-entry arrhythmia in which the junctional rate is more than the sinus node rate. That is why the junction would take over. This would occur in early post-operative period after cardiac surgery, and this is difficult to control, and the treatment is by reduction of the infusion rate of the catecholamines and control of the fever and pain. And if these measures do not work, then amiodarone intravenously is given, or sotalol. Now there is congenital type of JET. There is congenital junctional ectopic tachycardia. This is congenital and continuous and may lead to dilated cardiomyopathy if not controlled. And the treatment for the congenital JET is by catheter ablation, and if this would result in AV block, this is treated by placing an implantable pacemaker. Now let's talk about the atrial flutter. So in this type of supraventricular tachycardia, we have an intra-atrial re-entry circuit at a rate of 250 to 300 in children and 400 to 600 in neonates. And this rate is so high that the AV node cannot transmit rapid impulses such as like this. So some AV block is always present, and the AV node can respond to every second or every third or every fourth signal of these rapid impulses. So the ECG paper would look like this. So we have a flutter wave. So we have 2 P waves, and then we have a QRS complex, and then 2 P waves and a QRS complex, and so on. This is if the ventricle is responding to every second beat, and if the ventricle is responding to the third beat, then we have 3 P waves, then we have a QRS complex, and then we have 3 P waves, and so on. Now, atrial flutter occur in the setting of heart diseases and also occur after heart surgery. The treatment of atrial flutter include the DC cardioversion, and the patient should be anticoagulated before conversion, and the rate may be slowed down using beta blockers or calcium channel blockers. And if the DC cardioversion does not work, then class 1 and class 3 antiarrhythmics can be used to convert the rhythm back to normal, and catheter ablation is the definitive treatment for recurrent atrial flutter. Now let's talk about the atrial fibrillation. This is a type of supraventricular tachycardia in which there is an intra-atrial re-entry circuit that is more chaotic than in the atrial flutter. It has a rate of 400 to 700 beats per minute. The ventricular rate would be much slower than this, and this would produce an irregular ventricular response and pulse. And this is different from the atrial flutter because the rhythm in the atrial flutter is regular, while here it is irregular. So the atrial fibrillation would produce a fibrillation wave that is like this, and then a QRS complex, and then a fibrillation wave, then a QRS complex, fibrillation wave, and so on. And atrial fibrillation occurs in the setting of cardiac disease or systemic disease, and it is rare in infants and children. Now, regarding treatment of atrial fibrillation, if the patient is unstable, they are treated by DC cardioversion. They are converted back to normal rhythm. But if they are stable, they can be given rate control like beta blockers or calcium channel blockers, and they also given anticoagulation because there is a high possibility of the presence of a thrombi within the atria because they are not contracting correctly, and if they are converted without anticoagulation, the thrombi will be pushed into the systemic circulation. And after anticoagulation, they would be converted back to normal rhythm using DC cardioversion or using some medications like amiodarone. Now let's talk about the ventricular tachycardia. So in the ventricular tachycardia, the criteria of diagnosis is at least 3 consecutive premature ventricular contractions at a rate of more than 120 beats per minute. This would be diagnosed as an unsustained VT. This could be paroxysmal or incessant, and it is associated with cardiac disease such as hypertrophic or dilated cardiomyopathy, or it can be associated with the prolonged QT interval, Wolff-Parkinson-White syndrome, or drug use. Regarding the treatment of the ventricular tachycardia, if the patient is unstable, then DC cardioversion is given. But if the patient is stable, now although some children can tolerate this type of arrhythmia for many hours, there is still a risk of this arrhythmia degenerating into ventricular fibrillation, which lead to death. So it is important to treat it as soon as possible using amiodarone, lidocaine, or procainamide. Now, if treated, you should look for the underlying cause to prevent recurrence, like drug use, hypoxia, electrolyte disturbances, and try to correct them. Now, also, temporary or permanent pacemaker can be implanted to treat such type of arrhythmia, and if there is no clear cause is identified, then electrophysiological study has to be done to look for the cause, and an ICD device should be implanted within the heart to reinstitute normal rhythm in case the arrhythmia recurs. Now, in the ventricular arrhythmias, we also have the ventricular fibrillation. This is chaotic intraventricular re-entry rhythm that result in cardiac arrest. Treatment in this case is with cardiopulmonary resuscitation and DC defibrillation. You basically follow the CPR guidelines in treatment of this rhythm, and amiodarone or lidocaine can be the drug of choice for treatment of this type of arrhythmia. And if the rhythm goes back to normal, you should look for the cause, and if there is no identifiable cause, then the same applies as in the VT arrhythmia. there should be an electrophysiological study, and catheter ablation should be done, and an ICD device is implanted. Now let's talk about the long QT syndrome. This is mostly congenital, and the QT corrected interval would be more than 480 milliseconds. That is to be diagnosed as a long QT syndrome, and long QT is associated with Torsades de Boyns arrhythmia and ventricular fibrillation. These arrhythmias would result in syncope and sudden death. Now, long QT syndrome results from genetic abnormality causing this syndrome. Now, in long QT syndrome, we have a mutation in the cardiac potassium and sodium channels, and 13 variants of long QT syndrome are present: LQT1, 2, 3, and so on. Some of them are induced by stress or exertion, like LQT1. Some are induced by sleep, like LQT3. This means that the LQT3 have great risk of death, and these are treated by beta blockers. And due to the bradycardia that comes with beta blockers, pacemaker sometimes is important to be implanted because of the bradycardia, and ICD implantation is also done to return the rhythm to normal if the patient goes into ventricular tachycardia or Torsades de Boyns. Now let's talk about the short QT syndromes. In short QT syndromes, the QT interval is less than 340 milliseconds, and this would lead to atrial or ventricular fibrillation, and this is associated with syncope and sudden death, and it is caused by a gain of function mutation in cardiac potassium channels, leading to short QT syndrome. Now let's talk about the sinus node dysfunction. Sinus node dysfunction can present as sinus arrest, sinoarterial block, or sixth sinus syndrome. Now, in sinus arrest, there is failure of formation of an impulse within the sinus node. So there's no impulse formed within the sinus node, and this would lead to another part of the heart would take over and act as a pacemaker. Sinoarterial block, on the other hand, is when the tracts between the sinus node and the surrounding atrium is blocked, and that also would lead to another part of the heart would take over and act as a pacemaker. Now, those are rare in childhood, and they rarely may occur after cardiac surgery. Sixth sinus syndrome, on the other hand, occurs when there is a problem within the sinus node or the atrial conduction pathways. Sixth sinus syndrome occur after extensive cardiac surgery, such as infantile procedures, and atrial switch, such as mustard or Sinings, in transposition of great arteries. Now, patients with sixth sinus syndrome can present with bradycardia, normal rhythm, or tachycardia, but most of the times they are asymptomatic. Now, if they have bradycardia, they may present with syncope, exercise intolerance, and if this is frequent, they can be treated with pacemaker implantation, while patients with tachycardia who have frequent supraventricular tachycardia episodes may benefit from suppressive therapy using amiodarone, sotalolol, or other suppressive medications. Now let's move on to talk about the atrioventricular block. Now, the atrioventricular block, or also known as the heart block, is on three types: the first degree, the second degree, and the third degree. Now, in first degree heart block, there is a prolongation of the PR interval, and that is the only finding in this type. In the second degree heart block, we have Mobitz type 1 and Mobitz type 2. The Mobitz type 1 is called Winky-Bach. At this type, we have progressive prolongation of the PR interval. So on the first beat, we have a normal PR interval, then we have slightly prolonged PR interval, and then we have prolonged PR interval, and then we have a drop beat. So a drop beat, there is no QRS complex after it, and so on. On the second degree Mobitz type 2 heart block, we don't have a prolongation of the PR interval, we have a normal PR interval, but suddenly sometimes we have a drop beat, and so on. The P wave is present, we have a QRS complex, P wave, QRS complex, but suddenly we have a P wave and a drop beat. So sometimes the AV node allows the signal to conduct, sometimes it doesn't. On the third degree heart block, the AV node is totally blocked. There is no signals crossing from the atria to the ventricles. So the ventricle is beating by itself through a signal originating in itself. So we have the ventricle beating by itself. So we have a QRS here, QRS here, QRS here, and so on. And then we have the atria beating by itself. So we have a P wave here, P wave maybe here, P wave here, P wave here, and so on. Now, AV block is seen as congenital in patients who their mothers have autoimmune disorders such as Sjogren's syndrome or SLE, and they can be seen in patients with complex congenital heart diseases, and also can be seen after extensive cardiac surgery, or they can be seen after endocarditis or myocarditis. Now, in congenital AV block, it can present after birth, or it can be delayed after 3 to 6 months of age. And it is diagnosed with echocardiography, and maternal treatment with corticosteroids prior to giving birth is controversial. Treatment of AV block is with cardiac pacemaker. And with that, we reach the end of this video. Thank you guys for watching. Please give us a like, comment your ideas and questions, and please consider joining the channel by clicking the join button near the subscribe button down, or by following the link in the description of this video. Thank you for watching, and peace.